viewers, welcome back to pharmDpedia. We're going to discuss about pain pathways. So let's have a look on Introduction to Pain. International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is of two types, acute and chronic. Acute pain is of shorter duration and may be a symptom of a disease and it can be minimized. Chronic pain is of longer duration. It can be described more as a disease rather than a symptom. Pain is classified into two types, nociceptive pain and neuropathic pain. Nociceptive pain characterizes acute pain. It is a normal response to a noxious stimuli or a tissue injury such as skin, muscles, bones, etc. Nociceptive pain is of two types, somatic nociceptive pain and visceral nociceptive pain. Somatic nociceptive pain is a throbbing pain and is well localized. Example, muscles, skin, bone and joints. Visceral nociceptive pain arises from internal organs. Example, pancreas. Neuropathic pain. It is a chronic pain. The neurons from central nervous system and peripheral nervous system gets hyperexcited and due to their loss of inhibitory control, the abnormal signals are generated. When these abnormal signals reaches pain centers in brain, the pain is experienced. Behavioral, cognitive, social and cultural factors may also affect the pain experience. Behavioral factors such as anxiety, depression, fatigue, anger and fear lowers the pain threshold and increases the pain. Mental factors such as mood elevation, rest, sympathy, diversion raises the pain threshold and decreases the pain. Pain pathway is of four phases: stimulation, transmission, pain perception and modulation. Stimulation consists of stimulation of nerve-free endings. So, the receptors or nociceptors which are present on the free nerve endings in both somatic and visceral structures are activated by mechanical or thermal or chemical stimuli. The main reason behind the activation of receptors is due to the release of bradykinin, serotonin, prostaglandins, potassium, substance P and histamines. These activate receptors and generates action potentials which are transmitted along afferent nerve fibers to the spinal cord. Transmission. In transmission phase, the generated action potential gets transmitted to spinal cord through the afferent nerve fibers. These afferent nerve fibers are of three types: A beta, A delta and C afferent nerve fibers. Only A delta and C afferent nerve fibers are involved in nociceptive pathway. A delta afferent nerve fibers are large diameter and myelinated neurons. If these neurons get activated, then an individual experiences sharp and well localized pain. C afferent nerve fibers are of small diameter and unmyelinated neurons. If C afferent nerve fibers get activated, dull aching and poorly localized pain is experienced by an individual. These nerve impulses synapses in dorsal horn of spinal cord, leading to the release of neurotransmitters such as glutamate, substance P and CGRP. The third phase includes pain perception. The generated nociceptive signals are transmitted through the spinothalamic tract via second order neurons. These nerve impulses synapse in thalamus for the one last time and reaches the structures in the cortex via third order neurons. The structures in cortex include somatosensory cortices, anterior cingulate cortices and insular cortex. Modulation. Our human body consists of endogenous opiate system which modulates pain. This includes neurotransmitters and opioid receptors. Neurotransmitters such as enkephalins, dynorphins and beta endorphins. Opioid receptors such as mu, delta and kappa. These endogenous opioids like serotonin, norepinephrine, GABA and neurotensin binds to the opioid receptors and inhibits transmission of pain impulses at dorsal horn of spinal cord. Here is the pictorial presentation of the pain pathway. So, on noxious stimuli, the afferent nerve fibers are activated and the generated action potentials Here is a pictorial presentation of a pain pathway. So, on noxious stimuli, the afferent nerve fibers are activated and generates action potentials. These are transmitted through first order neurons to the dorsal horn of the spinal cord. Then the neurotransmitters such as glutamate and substance P are released. These signals are transmitted by passing through the spinothalamic tract to the thalamus via second order neurons. These nerve impulses synapses in thalamus and then the pain signals are transmitted to the cortex via third order neurons and hence the pain perception occurs. Clinical presentations. Signs of acute pain. It includes hypertension, tachycardia, diaphoresis, mydriasis and pallor. These signs are also seen in chronic pain. Signs of neuropathic pain. Chronic pain and the pain that cannot be well described. Hyperalgesia and allodynia are the main signs of neuropathic pain. Symptoms for acute pain include sharp or dull, burning, shock-like, tingling and shooting and radiating sensation. Symptoms for chronic pain. These symptoms are similar to acute pain but occurs without a temporal relationship with a noxious stimuli. Over time, its presentation may change. Example, that is from sharp to dull pain and obvious to vague. Diagnosis. Diagnosis is based on patient's description, history and physical examination as pain is subjective. We need to assess PQRST characteristics to know the quality and severity of the pain. In PQRST, P stands for palliative and provocative, Q stands for quality, R stands for radiation, S stands for severity and T stands for temporal factors. Treatment of the pain management includes non-opioid agents, opioid agents, adjuvant analgesics and regional analgesics. Here is the picture which shows the drugs and its site of action. Non-opioid agents. These are the first-line agents which are most effective with few side effects. These are used to treat mild to moderate pain. Non-opioids includes NSAIDs, salicylates, acetaminophen, propionic acids, COX-2 selective inhibitors, etc. Acetaminophen is an analgesic and antipyretic with poor anti-inflammatory effects. NSAIDs with their appropriate doses, routes of administration and frequencies are given below. Mechanism of action of NSAIDs. NSAIDs acts on cyclooxygenase pathway. It inhibits cyclooxygenase 1 and cyclooxygenase 2 enzymes. These in turn inhibits production of inflammatory prostaglandins, thereby reducing pain, inflammation and fever. Opioid agents. Opioid agents' onset of action is 45 minutes if administered orally and attains peak levels within 1 to 2 hours. These are given around the clock initially and can be changed to as required schedule after the pain subsides. Continuous doses of opioids may lead to addiction. In case of opioid allergy, different class of opioids must be selected cautiously. To treat this opioid allergy, mixed agonist-antagonist class is given as these drugs behave like morphine-like agonist. Opioid analgesics are generally administered through the routes such as intrathecal, epidural, subarachnoid, intramuscular and oral routes. ADRs like respiratory depression, hypotension, pruritus, nausea, vomiting, sedation and urinary retention occurs if these administered directly into the CNS. Opioid antagonist like naloxone reverses respiratory depression on continuous IV infusion. Mechanism of action of opioids. Opioids like morphine binds to mu-opioid receptors which are G-protein coupled receptors. It inhibits adenyl cyclase enzyme which produces decreased levels of cyclic adenosine monophosphate. Decreased cyclic adenosine monophosphate levels blocks the calcium entry and lowers the release of neurotransmitters. On the other hand, it acts on potassium channels leading to hyperpolarization of the cell. Therefore, the action potentials are inhibited and the pain gets diminished. Adjuvant analgesics. These are prescribed in chronic pain with a neuropathic component. Anti-epileptic drugs, antidepressants or local anesthetics are generally used as adjuvants. Anti-epileptic drugs like pregabalin and antidepressants include tricyclic antidepressants or serotonin norepinephrine reuptake inhibitors are generally used. Local anesthetics like lidocaine and capsaicin are generally used as adjuvants. Regional analgesics include local anesthetics, which are injected locally or applied topically. It includes two classes. They are esters and amides. Esters are procaine and chloroprocaine. Amides are bupivacaine with 5 minutes of onset of action and lidocaine and prolocaine with less than 2 minutes of onset of action. Thank you friends for watching our video. If you liked our video, please put a comment in the comment section. Please do subscribe, like, comment and share pharmDpedia.